Brewer. I'm a pediatric anesthesiologist. Okay. Have you guys seen these kids before? Okay, good. Not good, actually. Very bad. The presentation is about emergence delirium. Okay, so that's what we're going to talk about today. I did not get paid. Everybody's asking me how much they paid me. I did not get paid for this presentation. So these are the objectives. I want you to be able to recognize the characteristics of emergence delirium, and we're going to call it ED from now on. Okay, emergence delirium. We're going to identify what factors contribute to ED, so what to look for before the procedure, before the anesthetic, so that we can plan better. And how to participate afterwards when you see those kids in front of you. Okay. These are the questions. I'm going to ask you these questions at the end to see if you guys are paying attention. So with these two questions, if you are able to answer these two questions, basically you learn the most important things you need to learn about ED. Okay? So this is what you're going to look for. Which of these patients is at risk for ED? A 3-year-old that got sevoflurane and had an MRI, a 4-year-old that got sevoflurane and had a tonsillectomy, a 5-year-old that just had IV anesthesia for an inguinal hernia, or a 12-year-old that had sevoflurane for a procedure with Dr. J. And what medications are we going to use to treat emergence delirium? Which of these is the best one? Or which ones work, which ones don't? Okay. So, defining emergence delirium. Have you ever heard of emergence delirium? Yes. Okay. Is it really cool? No. Okay. So how would you describe it?
Crazy. It's really awful.
Crazy? Did I hear crazy? Yeah, really awful? Mm-hmm. Can you console the kid and tell him, it's okay, it's okay? No. So, inconsolable. Will they sit still if you...
Dangerous.
How many people do you need to hold them down? 5. Are you worried about the IV staying in place? Yeah. Okay. So very good, exactly. Everybody knows what it is. So the first person that decided to write it up was somebody called Dr. Levi, and that was in 1945. Okay, which is pretty much with anesthesia, kind of modern anesthesia started. You can call it emergence agitation. And then there's all these fancy ways to describe it. Dissociative state of consciousness. Perceptual disturbance with psychomotor agitation. Yeah, the thrashing. Okay? And just being inconsolable and non-purposeful. Okay? So even if you bring the parents in and the parents are telling the kid, it's okay, you'll be fine, they're going to give you pain medicine now, their eyes are going to be glazed over and they're just going to be crying. Okay. So that's the patient. Okay. Characteristics of emergence delirium. Where do you think this is going to happen? Is it going to happen in the cafeteria? No. Okay, so where are we going to see it? In recovery, right. Okay. This is a tricky question. Can everybody get emergence delirium?
Yes.
Everybody that had anesthesia. Yeah. Everybody that had anesthesia. But who are we most worried about, being that this is a pediatric conference? Children. Children, yeah, children. And so the people with most increased risk are between the ages of 2 and 10. And you can kind of see that from the patients that you've had before, right? Okay. Is it a very common thing? Yeah. A lot of children that age can get it, okay? Especially when you're 5 years old, 6 years old, those are worrisome. Okay. How about if your patient's gonna be a boy versus a girl, are you more worried about one or the other? No, it's pretty much the same for everybody. There's no difference. So the emergence delirium will last you about 10 to 15 minutes, okay? Some say it can last up to an hour even. But, you know, maximum 30 minutes, really. Hopefully after 30 minutes it'll calm down if you don't do anything, okay? But hopefully we'll learn about stuff to do, okay? They, like we said, they can harm themselves, pull out the IVs, scratch people that are trying to hold them down, delay discharge later from the hospital, okay? And if the parents are there to witness it, they're gonna become very worried and maybe upset about their child having been tortured in the OR.
If a child has multiple anesthetics, if the child presents having emergence delirium one time, are they at increased risk for having it again? Or is it a predictor?
It's a predictor, yes, and we're gonna talk about that right now.
Sorry.
No, very good, said William. Okay, what are the risk factors for this happening? Okay, so I've divided it in three different columns, right? The patient factors, what are we gonna look for the patient? The anesthetic factors are what anesthesia type was used, and the surgical factor, what surgery did they get, okay? So, like we said, children below the age of 10, okay, and starting from age 2, when they also start getting that separation anxiety. Because little babies, when they're 1 year old, maybe they'll cry because you're not letting them sleep, but they're not really gonna care very much about separating. So if the patient himself is very anxious, that's a risk. Or if the parents are also anxious, so a whole anxious circle, anxiety circle, those can be risk factors. And down below there, if they had a history of emergence delirium before, that's a risk factor for having it again, definitely. Okay, I'm gonna go to surgical type. What surgeries are we gonna watch for? Tonsillectomies, adenoidectomies, okay? So remember the questions we did. Okay. So ophthalmology surgeries, basically ENT, head, and so from here above, they're gonna be upset, more upset than usual. Anesthetic technique, okay? Sevoflurane, isoflurane, desflurane. Those are the anesthesia gases that we use now, okay? We don't use halothane anymore. They saw that when these new anesthetic gases started coming out, the patients were suffering from emergence delirium more than they did with halothane. Okay, so these are different. And they're all equally likely to cause it. Not one more than the other, even though at some point they thought it was. Okay. And then rapid awakening. So if the patient wakes up really fast, there are higher risk of getting emergence delirium. And that kind of makes sense when you think about this type of surgery, tonsillectomies. Those are very quick. So that's what the patient might have. And poor pain control. Okay? So the pain control can also be, pain can be a confounding factor. So you're gonna see, kids are crying just as they would be crying when they have pain. So that's gonna be confusing. Does this patient have emergence delirium or are they in pain? Okay, we'll talk about that. Okay. I didn't know how to name this slide, so I call it notes to know. Pre-op anxiety is associated with more pain post-op. Okay, somebody that's very anxious is going to have more pain. They're going to have more pain later. And what we talked about, agitation due to pain is a confounding factor for emergence delirium. So they're all coming together. They're all together. An anxious patient having emergence delirium will have more pain. Okay, it's things that we want to take note of and try to ameliorate. Okay, to identify emergence delirium, we all know it, we talked about it, you guys saw the pictures of those kids and they seem very familiar to you. So you know how to do it. Now some fancy people try to make some tables to help you identify it. Okay? So, like if you have a patient with ED, you're going to take out this table. One. So let's go through it. What do they want you to look at? Are the movements that this patient is what he's doing purposeful? Not at all, you get 4 points. Or, yes, very purposeful, 0. Is the patient making eye contact? Are they aware of their surroundings? Are they inconsolable? Are they restless? So all of these are given points, and if you add up more than 10 points, magic, you have emergence delirium. So these are other these are other tables that they made that are a little bit simpler, shorter, quicker, that you could take a glance at and say, okay, this is definitely it. But what's the difference? Here in this watcha table, you see agitated and thrashing. That's what we said. Somebody said that thrashing, the patient is thrashing. So that's different. When they're crying, than being crying and consolable. Crying and consolable means you hold the patient or the parents are able to come in, you can give them water or you can give them some pain medication and they'll be consolable. That's different from agitated and thrashing. They're not making sense. It's like not even being there. So those are the tables.
I think that's what's the most upsetting to parents is because their normal comfort measures don't work at all.
Right.
They're just like freak.
And they'll tell you, oh, it's like he's not even himself. He doesn't know who I am. And they become distraught too. Yeah. Okay, so now to the good part. We're gonna prevent it. We're gonna try to prevent emergence delirium. Okay. So how do you do that? Well, you prepare before surgery. And you guys help a lot in that when you call the patients or the family members before, on the day before, that's actually really important for the anesthetic. It's been shown that when the patients are called or they get some information about the anesthetic before, their anxiety levels go down that day of surgery. So it's like they're aware of what they're going into, okay? The child life specialists are a great help and very important to help with the pre-op anxiety, and now we know diminishing pre-op anxiety will help diminish pain and diminish emergence delirium. So pain for everybody goes down. So call the child life specialist. They will help in presenting the masks to the patients and walking them through, and so that they'll be less scared. You can also do distraction techniques, and many of you have seen when they're playing when the children are playing video games, they are not talk to the hand. They don't even want to know anything about you, right? They're just playing the game, and that sometimes it doesn't work, but many times when they like that, it helps them get away from this anxiety. You can use parental presence.
Attention all departments, please return all surplus pneumonic tubes to station 0. Attention all departments, please return all surplus pneumonic tubes to station 0. Thank you.
You're welcome. So the patient's parents, if they're not anxious, right? If they're calm people that are following instructions, they can come in and help with induction, okay? Because that'll lower everybody's anxiety. Or you can give a pre-medication with anxiolytics, which many times we do pre-medicate with benzodiazepines. Okay. And none of these are better than the other, but they're better than nothing, definitely. Okay. There's other hospitals that have a more rigorous setup when the patients are going to surgery, and they use all these techniques, and the patient goes through a preoperative phase that's more rigorous. So they go through anxiety reduction, distraction videos, education, everything before they even come to the hospital, so that they're more familiarized. And then, and this is everything that we can do pre-op. Intra-op, as the anesthesiologist, what we can do, if, for example, we have a patient that's at very high risk, that is between the ages of 2 and 8, that's having a very painful procedure, and has had emergence delirium before, maybe for them, we can make a plan to use TIVA, which means total intravenous anesthesia. Basically, it means not using the gases, which are very quick to go on and off, but using the anesthesia that you put through the IV, and that will allow for a slower wake up and help preventing emergence delirium. Okay? Also very important for us as anesthesiologists, and later in the pre-op, in the post-op period for the nurses, to help with the pain management. So because that's one of the confounding factors, and you will still have a crying patient if they're in pain. Okay, so this is a little self-promotion. When I was a resident, my hospital didn't have a separate pediatric surgery area, so all the little children were mixed in with the adults, and it even gave me anxiety. So I made a little booklet for them to take them through the anesthesia, what was going to happen. But this is just an example of the distraction techniques that you can use for the children, and many of us do it, you know, when we talk to them, when we ask them, oh, how many brothers and sisters do you have? What grade are you in school? Look, all of these things distract them and take their mind away from the scary thing that's happening.
Did you draw this?
Yeah. Okay, treating emergence delirium. Okay, to treat it, this is going to be done in the recovery room, as we have said. This patient is going to be in the recovery room. How do we treat it? Well, first we have to think about what else could it be. We have to make a differential diagnosis. So is this patient in pain? Is this patient having a metabolic disorder, that they're not breathing well, that they're not getting enough oxygen and now they're confused because they're hypoxemic? Maybe they're hypoglycemic and they're also not thinking well, or you know, they have a headache because of the hypoglycemia. All of these things are differential diagnosis for emergence delirium that have to be in our minds when it's happening. So you need to ensure patient safety. When you see a patient that has emergence delirium, everybody calls for help, everybody knows to come to help. And hopefully we haven't called the parents in yet so that they don't become scared. But if they're there, we just tell them this is something that happens very commonly to children during an anesthetic. We're going to take care of it now. We're calling the anesthesiologist and we're going to give them medication so that they calm down and, you know, reassure them that everything's going well. Pharmacological intervention. So pretty much this is what you're going to do, because once the patient has emergence delirium, as we said, we can't reason with them. We can't tell them, oh, please stop. They will continue to do that and hurt themselves or kick people in their face. So what can we do? There's different medications there, okay, that everybody's familiar with. Midazolam.
Attention all departments, please return all surplus pneumonia to station 0. Attention all departments, please return all surplus pneumonia tubes to station 0.
So these are medications that we use during the anesthesia. Midazolam we can give at the end if they're having emergence delirium. We can give propofol, but these are lower doses than we would for the induction of anesthesia. Okay, fentanyl, which is good because it covers emergence delirium, but it also covers pain. So if you're not sure if your patient's having emergence delirium or pain, you can give them fentanyl, and they'll have both covered, right? And then dexmedetomidine. The other three medications above are older medications that everybody's familiar with, and by now most people are also familiar with dexmedetomidine. It's also called Precedex. And so this medication also helps you with the emergence delirium. And like everything else, these medications have their risks versus their benefits, right? With fentanyl, it's very good for pain if the patient is in pain and is having emergence delirium. But we want to be careful when we give it because, well, what can fentanyl do like other opioids? Respiratory depression, right? So even though these are small doses, maybe after an anesthetic when they received a big amount of fentanyl or any opioid, maybe you want to say, oh, maybe my patient's not going to be crying, but they're also not going to be breathing that much. So that's what we want. Okay. So dexmedetomidine. Has everybody heard about dexmedetomidine? Yes, very good. So, what is it? Great, yes. Good job, yes. So this medication is similar to clonidine. Have you heard about clonidine too? Yes. So actually it's like clonidine, but it's highly selective, not just selective like clonidine. Okay, so it's an alpha-2 adrenergic agonist. And it indirectly increases inhibitory GABA. And what that means is that it helps depress the nervous system, but indirectly. Okay, so that the patient will calm down, basically, is what it's saying. And these are all the different vials of Precedex that you'll see. Okay, so I'm biased for Precedex. I like using it, right? Even though I told you all these other medications are good for emergence delirium too, Precedex is good too. And what I like about it is that it helps with anxiety. It sedates, right? It has a little bit of pain control that's in there. Okay? But when you give the prosthetics, the patient is going under a period of natural sleep. So different from the rest of our anesthetics, where the waveforms when you see in EEG are not the same as natural sleep, but when you're having a patient with prosthetics, the brain waves look the same as when you're having natural sleep. So even though your patient is next to you snoring, if you wake them up, they're like, huh? They'll answer you, right? But if they're deep on their propofol, you're not going to wake them up if they're deep under them. Okay? So that's why it's good. With prosthetics also, even though fentanyl is great and it works for pain too, it also, like we talked about, has respiratory depression. With dexmedetomidine, you don't have that. So you can give a large amount of dexmedetomidine and still have the patients breathing well. You don't have to worry about that. And with the opiates, you're also worried about nausea, which prosthetics won't cause. And that's why I'm partial to prosthetics. Now, you do have to, especially with pediatric patients, be aware you can't just plug it in, because it can give bradycardia. And that's what, and maybe some of you that know me, maybe you've seen some of my patients that are snoring and their heart rate's kind of slow. Well, now you know what happened. Okay? Because it'll give bradycardia, but just watch them. If they're bradycardic, there's medications also that we can give to speed that up. But many times it's a stable thing. Okay. So what are the conclusions? What I want you to take home. Emergence delirium is common. Okay, from 20 to 50% of patients can have it, and it happens in young children that have general anesthesia. Okay, you can do behavior modification interventions prior to the anesthetic to try to reduce the incidence of emergence delirium happening. And once you get a patient in you can't always prevent it, right? So if you get a patient with emergence delirium in the recovery room, you can treat it with sedative medications, and that way you'll reduce the risk of harm to the patient, to the staff, and to the caregivers. Okay, so rather than hold them down, we can give them medications and make them more comfortable. Okay, so now, back to the questions. Okay, which patient is at highest risk for emergence delirium? I was gonna have you ask. Everybody knows it. Okay, very good. Patient B. Why? TNA, he had SIBO. Okay. Now, a tricky question. Patient A, can that patient have emergence delirium?
Yeah, that's what I thought first, because when we get the BMTs, they've had SIBO and then they just wake up, so that's why I went for A first.
Yeah, so even though pain can be a confounding factor, and before studies were made, they thought that emergence delirium was due to pain, they've seen that patients that have an MRI, which doesn't hurt, still get emergence delirium. So it can happen to them also. Okay.
Do you think that's because they just get SIBO exclusively and they don't get anything else to help them out of it?
They do.
They get other stuff?
Yeah.
Oh.
Well, it depends. So you can look at the chart, right? Some people, for example, when I have a patient that has a BMT, I put fentanyl in one nose and prosthetics in the other nose, and toradol in the arm. Even though, it doesn't hurt. I don't know. I've never had a meningotomy, but I know that they're going to wake up mad. And I don't like that. Yeah. So, which medications can emergence delirium? All of them, yes, very easy, all of those things. And, okay, if your patient's having emergence delirium and the anesthesiologist tells you, I'm going to give him midazolam, are you going to be mad because now that's going to delay discharge? No. No, yeah, because the delay of discharge is going to be that patient rolling around, ripping out the IVs, kicking somebody in the face, sending them to workman's comp. That's it. Yeah. Okay. That's it. That's emergence delirium.